Good morning, everyone. My name is Alana Dillon. I'm an Education and Support Services Coordinator with Parkinsons Society BC. I'll be facilitating our webinar today. Thank you for joining us this morning for our Ask the Expert webinar on eye health in Parkinson's with neuro-ophthalmologist Dr. Jason Barton. Before we get started, I want to go through a few housekeeping items. First, I want to let you know that the slides and webinar recording may be available on the website. They will be available on the website, and it may take a week to process. Secondly, you will see a chat box at the bottom of your screen. If you click on that chat box icon, it will open up for you to type any of your questions and comments for Dr. Barton. And finally, to optimize your experience with this webinar, please ensure that you adjust your speaker volume both on your computer as well as on your actual speaker so that you can hear the webinar well. I would now like to introduce Dr. Barton. Dr. Jason Barton obtained his MD from the University of British Columbia in 1984, where he completed a neurology residency in 1990. He was a fellow in neuro-ophthalmology at the University of Iowa from 1990 to 1991 and the University of Toronto from 1991 to 1995, and obtained his PhD from the University of Toronto in 1996. He was assistant and then associate professor of neurology at Harvard Medical School and director of neuro-ophthalmology at the Beth Israel Deaconess Medical Center from 1996 to 2004. Since 2004, he has been director of clinical neuro-ophthalmology at Vancouver General Hospital. He is currently professor in neurology, ophthalmology, and visual sciences and psychology. His research is focused on cortical processing of vision, in particular high-level object perception, such as face and word recognition, and also on the use of saccadic eye movements to explore issues of cognitive control. We are very lucky to have him here today. I'd like to pass it over to Dr. Barton now. Dr. Barton, welcome, and thank you for being here today.
Thanks. Now, I was here about in 2018, I realized, as I brushed through my old records. So some of you might recognize me. I'll see how many people leave the seminar, but in that case. And for those of you who were here before, it was a very similar topic. So I apologize if you were here in 2018, you might hear some similar things. I have added some extra stuff, but I realize not everybody was here. So for the benefit of those who weren't here in 2018, we will discuss some of the same issues. Now, of course, we'll come to the challenging moment of any Zoom presentation, which is trying to figure out if your share screen function works. So let's see what happens. Okay. Is that on or not? I put it to full screen.
Looks good.
Okay, good. So yeah, I call this the eye and vision because there are some things about the eye that are only indirectly involved with vision, but are still issues that people come to see ophthalmologists for with Parkinson's. And vision also includes eye movements in this case, which we will finish the talk with because that is an issue that I was particularly asked to kind of address, particularly the role of eye movements in maybe helping to diagnose Parkinson's. So, which is something we didn't discuss last time. So this is the structure of what we're going to talk about in the next 45 minutes. There's really three avenues: ocular surface problems, which is the front of the eye, vision in Parkinson's disease, and then eye movements in Parkinsonism. And I say Parkinsonism because not everybody who has a Parkinson-like problem has Parkinson's disease. Some of you may well be aware that there are other kinds of Parkinsonism which differ from Parkinson's disease, but can look fairly similar. And often part of the challenge is trying to tell who has what. So ocular surface problems, what we're going to start off with, this is very common issues, not only in people with Parkinson's disease, but also in other people. And it's estimated, for example, that out to 7% of women over the age of 40 have a dry eye problem. But these are issues that are particularly heightened in Parkinson's disease and often will lead to people coming see me to have these things addressed. I will say at the start, you don't need to see a neuro-ophthalmologist to have dry eyes and blepharitis managed. Most general ophthalmologists and optometrists can handle this quite well. And in fact, optometrists are actually very good at this. So if you have these problems, you don't necessarily need to work your way up the medical food chain. I think your optometrist around the corner can probably do this just as fine a job as I can. So what is special about dry eyes in Parkinson's disease? Well, you know, in most people who have this, it's reduced tear formation. And sometimes the reason why you have reduced tear formation is because the glands that secrete some of the oily parts of the tear are inflamed, and that's what's called blepharitis. But there's the additional issue in Parkinson's disease of blinking less. And if you imagine, you know, that blinking is like a windshield wiper. If you don't do it often enough, that windshield, known as a cornea, is going to get dried out, and that's not going to feel very comfortable. And then you're going to start feeling things like burning, a gritty sensation, like you got something in your eye, but actually there isn't something in your eye. And in response to this burning, gritty discomfort, your eyes will actually paradoxically make more reflex tears. These are the tears that are elicited by emotion or pain. So they're not quite as good as lubricating the eyes, because they're coming from the lacrimal gland, which is a different structure. So ironically, people with dry eyes can sometimes present with a wet eye, excess tearing. And if the cornea dries out enough, then its surface gets a little irregular, and that makes vision blurry, or even sometimes a little ghosting and doubling going on. So if you get those symptoms, there are some things that we look for. So if you go to the optometrist, ophthalmologist, and they put drops in your eyes, well, sometimes those drops are for dilating your pupil, but sometimes they're actually to put a little bit of dye on the surface so that we can see what the cornea looks like, and if that's any areas of the cornea that are eroded away. And that's what we're seeing here. You can see in the green, there's this big plotchy spatch of green stuff on this left side, and on the right side, there's this purple sticky bits. And those are indications that the eye is, the cornea is starting to lose its surface regularity. And that's probably a sign that you got to take your dry eye problem a little bit more seriously. And what can we do about it? If you have this, the very first step is to try artificial tears. These are over-the-counter things you can get at the drugstore. There's usually a full rack of, tens of these different kinds of artificial tears from different manufacturers. I'm not trying to advertise any of them here particularly. All I suggest is if you get them, you can ask the pharmacist for some advice as to which ones have more gel-like qualities. So these are a bit more viscous, and they will last longer than if you get the more watery types. But that being said, artificial tears don't last that long. They're not really a drug because they're meant to kind of mimic your own tears. So they're kind of like a saline solution with a few little other things added to it. But you may end up having to apply these several times a day, and also when it bugs you, which is totally fine. You can use these quite liberally. However, at some point, it becomes a little inconvenient to be kind of plonking drops in your eyes every hour or something. And in that situation, you can use a gel. So all of these artificial tears also come with a gel in a small toothpaste tube-like thing. These are often used by people when they go to bed at night, if they happen to wake up in the morning and their eyes are uncomfortable, because that might be a sign that they don't really properly close their eyes when they sleep. You can also use this in the daytime. It's a little sticky. It feels like Vaseline in your eye, and it's a little blurry, but if you blink a few times, you can get a nice even spread, and the effect on your vision is not too bad. And that's how I often use it when I have to go cycling in a strong wind. If the gels and the tears aren't enough, then the next step up, and I'm just giving you a little bit of a sense of how we go through the upgrades and treatments here, so you know what's available. These are punctal plugs, and I'm showing you here on the right what a punctal plug looks like, and it's inserted into this little hole on the inside of your eye, which is essentially the drain through which your tears are removed from the eyes into your nose. That's why your nose gets stuffy if you cry too much. So it's simply because it's simply plugging the drain. It's going to slow the removal of your own tears or any artificial tears you put in your eyes and allow your eye to stay moist longer. There are also gel inserts that you can put in that will not be quite so long-lasting as an actual physical plug like this. That you do need a, you obviously can't do this over the counter. You need a little help from the optometrist or ophthalmologist to put these in. So one thing we do look for is blepharitis. So what I'm showing you in the bottom here is essentially a cross section through an upper lid there. You can see the skin, the muscle, the hair follicle. And on the inside of the lid is this meibomian gland, and that is the thing that secretes this oily film, which is essentially what lubricates your eye. And one of the things we find is that if you have increased sebum production, and some patients with Parkinson's have a problem with seborrheic dermatitis, little known fact. And having meibomitis is essentially like a seborrheic dermatitis of your eyelid. And if you have this, you are going to reduce the production of your own tears because the glands get blocked. And so this can actually cause or aggravate dry eyes. So you might find, in addition to the symptoms of excessive tearing and the gritty burning sensation that anybody with dry eyes have, you also may have a little bit of redness along the rim of the lid or some crusting. As you can see in this picture here, you can see where the eyelashes originate from the eyelid, which is just in front of where the meibomian glands sit. There's a bunch of stuff here that's flaky, like dandruff material. Clumping of the eyelashes is also kind of a sign of this. And you might also find that with this problem, with this inflammation, you get a bit light sensitive. So here's a bit of a close-up so you can see that crusting that's gathered at the along the foot of the eyelashes. So this requires a bit more than just using artificial tears. There's a lid hygiene protocol that all ophthalmologists and optometrists are very familiar with. Often this involves, when you get up, putting a warm compresses, which is quite as simple as a face cloth that you've run under the hot water tap for a bit. Don't burn yourself. And just applying it to the lids for 5 or 10 minutes. You can use it to massage the lids gently. Some people even suggest maybe adding a little baby shampoo, which will kind of sort of degrease these glands. And if you just do it on a regular basis, you might find that the inflammation will go down. If it doesn't, you might need something a bit more aggressive, like even an antibiotic or steroid, or what's commonly used is this immunosuppressant eye drop called Restasis, which is a cyclosporin. Clearly, these are more, you do need help with an ophthalmologist or optometrist to get these kinds of medications. Anyway, these are common problems, and if you have any of those symptoms, check yourself in the mirror, see whether you got blepharitis, and then try the artificial tears if you want. You don't need to see the doctor for that. You can do the experiment yourself and see if it makes your eyes feel better. So that's kind of some very simple practical things that many people with Parkinson's do have to work through. Vision perhaps is a more interesting issue, and maybe not quite so practical. There are 3 things really with vision that go on in Parkinson's disease. One is, could there be some problems with the retina itself? The other is, how about problems that derive from the parts of your brain that handle vision? And finally, a common clinical problem that we have to deal with is hallucinations. What do they mean and what do we do about them? So talking about the retina first, we all know that Parkinson's disease has a problem with dopamine transmission, right? In the case of Parkinson's disease, it's a problem with manufacturing, the cells that manufacture the dopamine, and some of the other Parkinsonism syndromes is a problem with the cells upon which dopamine acts. In any case, one of the things that people are less familiar with is that the fact that there are cells in the retina that also use dopamine as a neurotransmitter. These are called the amacrine cells. So what I'm showing you at the bottom there is a cross section through the retina. The inside of the eyeball is on the bottom and the outside is on the top. The big black strip there is a pigmented layer of the retina called the RPE, retinal pigment epithelial layer. And just below that in this picture are all these vertical stripes. Those are the rods and cones, the outer segments. And the cell bodies of these rods and cones are that first very thick ray of purple blotchy circles. And those are the nuclei of the rods and cones. But the next layer down of purple dots is the inner nuclear layer, and that's where amacrine cells live. And the very bottom is the nuclei of the ganglion cells, and these are the start of the nerves that go from the eye to your brain. So what would happen if you lose amacrine cells? Well, you don't really know for sure, but there are some speculations that this could account for a slight reduction in the sharpness of your central vision, which we measure as acuity. You know, if your 20/20 essentially is a measure of your central visual acuity, how sharp and good you can resolve detail with the middle of your vision. Color vision has been speculated to perhaps depend a little bit upon this and might take a hit. And contrast sensitivity is the ability to tell fine shades of gray and shadow, which is actually just as important as acuity. Acuity essentially is what you can see when things are black and white. But the world isn't black and white. The world has lots of fine shades of gray and shadow, and that can be perhaps a little off even in someone who can see 20/20. I don't find really a lot of people complaining of these things, but so it's a subtle issue at worst, I think. But you know, studies have shown that there are some issues with this if you check carefully enough. Now, that's kind of talking about the function, but how about how the retina looks? Can we actually see? Are there any changes in the way the retina looks because of this? So on your left, there's a picture. If I look into the back of your eye, I might see a picture like this, usually in color, of course. But this is a grayscale picture taken by something called a machine that measures optical coherence tomography, which goes by the nickname of OCT. And what OCT can do is it can not only take this picture, but it can also, using light waves, segment this in 3 dimensions. So on the bottom right there, you can see essentially a cross section through the middle green line on the left side. If you were to just to saw down through that, this is what the cross section looks like. And this essentially is seeing all the different layers of your retina, which I've depicted from the previous page above it. So this is upside down, so the retina is at the bottom and the ganglion cell layer is at the top. So people have been interested in the idea of, well, if there are some dopamine cells in the retina, can we find that actually the structure of the retina, is it different in Parkinson's disease or other conditions like progressive supranuclear palsy, which is one of those Parkinsonism conditions that isn't Parkinson's disease, but has many similar features. So I will say that people are looking at this, and all I will mention is that we did look at this actually in 2020, and we found that actually if we measure the nerve fiber layer, okay, this is not actually the amacrine cells, but the nerve fiber layer, which is the thing that we have the most data for, that is reduced in progressive supranuclear palsy, but it's not reduced in Parkinson's disease, which you can sort of see in that graph below, where the control subjects are on the left, the Parkinson's disease is in the middle, and they look very similar to controls, but the PSP patients are a little down in thickness compared to the other 2 groups. What we don't have yet, though, is a way of measuring the inner nuclear layer reliably and statistically. And that's, of course, is where the dopaminergic amacrine cells live. But I think that will come one day. We can already measure the outer nuclear layer, but the inner is a bit thinner and a bit more subtle. So still waiting for technical developments to improve our ability to look at that in Parkinson's disease. Now, how about the brain? There are reports in the literature that some patients with Parkinson's can have problems with identifying faces or facial expressions or navigating their way around space, which is a brain function too. So these involve networks. It's not just like one area of your brain that sees a face or that tells you where to turn left. These are all brain networks involving the occipital, the back part of the brain, and the temporal lobe and other things. Again, I don't think this is a major cause of symptoms, but maybe we're not asking enough people about this. What we do know, though, is that there are certain types of Parkinson-like conditions where involvement of the brain is probably more severe and noticeable than regular Parkinson's disease. So one of the pathological features of Parkinson's disease is a Lewy body, and but it's usually confined to the midbrain in regular Parkinson's disease. But in diffuse Lewy body disease, it's in many, many places of the brain. And so maybe it's not surprising that in that case, this disease is characterized by more brain problems than in regular Parkinson's disease. And they will have some of these other symptoms more prominently. Now, one thing that is also important, not just in Lewy body disease, but in Parkinson's disease, is hallucinations. People estimate that up to 25% of patients with Parkinson's disease can have hallucinations. And if they have them, they're exclusively visual. So unlike the case with psychiatric disease like schizophrenia, where most of the hallucinations are auditory, in Parkinson's, it's visual, and they're complex. They're not simple swirling shapes and things like that. They're actually figures and faces, kind of complicated things. Who might get this? Well, the longer you've had Parkinson's and the more severe Parkinson's, the greater the likelihood that you might start to experience something like this. Depression and insomnia, it's hard to know exactly why that should be, other than that insomnia perhaps can facilitate a bit more confusion, and that in itself carries a risk of hallucinations. And if there is associated cognitive impairment on a related theme. So there's early problems with dementia, hallucinations may be one of the signs of that kind of creeping in, which is most unfortunate. People speculate that one thing that might be a critical factor is disruption of REM sleep. And that may be where the insomnia thing comes in too. We know that one of the early symptoms of Parkinson's before the motor manifestations come in, even maybe the acting out, sleeps in your dream. These are all kind of sleep regulation problems that can occur. One important thing, though, that needs to be sorted out at a more practical level is, well, maybe it's the medication doing it, because that's got a quick fix. Maybe if we adjust the medication, we can get rid of the hallucinations. So that's always something that your neurologist will be thinking about if you complain of hallucinations. They'll be wondering if maybe it's the medication that needs to be titrated in some fashion. But again, one of the important things that we think of as well, besides worrying about whether we're doing it to you with our medications, is whether this means that you have what we just discussed, diffuse Lewy body disease, rather than just Parkinson's disease. So there's four things it comprises. One is Parkinson, like motor problems. Another thing is sleep-wake cycle inversion. So these people tend to be drowsy in the day, take naps, and up at night. Episodes of confusion that come and go. And then 90% of these people have hallucinations. So we don't know for sure, but there's a thought that maybe the hallucinations are a marker for having Lewy bodies in your anterior temporal lobe. But there's also a thought that maybe it's more to do with connections between the midbrain and the pons that impairs REM sleep control, and that not only results from the sleep-wake cycle inversion, but also increases the risk of hallucinations. So what are you going to do if you have hallucinations? Well, again, the first thought is make sure it's not something that the doctor is doing to you. Stop the drugs that are increasing the risk of hallucinations if you can, or see if you can modify the dose if you can't. Then there's the thought that, well, if your vision's not great and you're not wearing the right glasses, maybe, can we fix that? Or if you have cataracts, if we remove the cataract and improve your vision, will that result in a reduction in hallucinations? Maybe the hallucinations are telling you that not only do you have Parkinson's, but maybe there's something about your vision that's a little off that is possibly correctable. So this is the idea that maybe there may be a deprivation component. One of the things we know is that if people lose vision, like let's say, they have bad cataracts in both eyes, or they have a stroke that removes part of the visual, everyone just them a bit blind from loss of brain tissue. These people can start to hallucinate. It's called a release hallucination. It's as if the brain, in the absence of visual input, starts to make things up. And so there's a thought that this might be a contributing factor in some patients. So always worth checking to see if your glasses need to be fixed or if maybe cataract surgery is indicated. Some people have tried using drugs that are used in Alzheimer's or REM sleep disorders to see if those can help reduce hallucinations. Generally, we've not had to go that far to try to do this. All right. So eye movements. This is the section I'm going to spend probably the rest of the time on, because this is important to me and important to some of you as well. I do run an eye movement lab as well as a brain function lab. So I'm always interested to see how eye movements work or don't work. There's 5 things I want to talk about here. And the last one is the topic that we didn't discuss last time. So we'll talk about the diagnostic utility of all the things that we're talking about here. Convergence insufficiency is probably the most common cause of complaints of double vision in Parkinson's. And it's estimated about 30 to 50% of patients have this to some degree. I don't think it's causing symptoms in everybody. I will see people in clinic sometimes and I can tell that their eyes don't converge, but for whatever reason, they're maybe suppressing the image from the second eye, or maybe their eyes are able to kind of click it together when they try hard enough. They don't see the double vision part. And that is a key thing. If you're wondering if you have a convergence insufficiency, it might be causing some problems. The problems it could cause for you are that you see horizontal double vision. That means the images are side by side. If it's not super far apart, it might be close enough that you just see it as a bit of blurring of vision. Kind of like, you know, when the newspaper gets the imprint in the old days when they had the blue and the yellow and different prints and they didn't quite register them properly, then you get this kind of fuzzy appearance. Same idea. Or maybe some non-specific complaints like fatigue or strain with your eyes. Now, the key thing is that these are symptoms that you should have when you're reading or watching TV, not when you're looking down the road or, you know, outside down the street. Because it's a problem with convergence is something you use when you're looking up close, not when you're looking at far. So this just illustrates the point. You know, the eyeballs seen in the bottom here, when you're looking at a car in the distance, tend to be relatively straight. But when you're reading and looking at something really close to you, you have to turn the eyes in. That's what convergence is, right? And that's what people with convergence insufficiency can't do very well. And so if you can't do that well, then your eyes don't align and you see double. Now, why should this be involved in Parkinson's? Well, it's because the neurons that control convergence are located in the midbrain. And so here is an MRI scan showing you what the midbrain looks like. It's that funny Mickey Mouse-like thing in the middle. And here's the same thing on a pathology specimen on the left. And on the right, so these are what we call axial diagrams. You can see the eyeballs at the front and then the back of the head at the back. So it's slicing horizontally. But if we slice vertically, then we get what we call sagittal section. That's what this picture is here. And the midbrain is right in the middle there, where hopefully you can see my cursor swiggling around. So, you know, the convergence insufficiency convergence is generated in this general area. And if you have an insufficiency problem, it does seem that it might correlate with the severity of your Parkinson's. This is not unique to Parkinson's disease. Anybody with Parkinsonism, you know, like PSP and other things, can get convergence problems as well. So if you've got this and you're seeing double when you're looking up close, what can you do about it? Now, there are convergence exercises that optometrists or orthoptists can help you with. Some of these are things you can do at home. They're often called pencil push-ups. You look at a pencil and try to bring it as close to your eye as you can and until it goes double, and see if you can sustain it there and see if you can, with practice, get it closer and closer. But there are also office-based programs as well that might be a bit more effective. Problem with these things is that they're shown to work in kids who are born with a problem with getting their eyes to cross. What we don't know so much is whether they work in somebody who is an adult and gets this because of a disease problem. Because it's quite possible that the neural mechanisms you need to learn from exercises is what you lose when you have a disease process. So you could argue that we don't really know for sure if these exercises really make a huge difference in Parkinson's or other neurodegenerative problems. And of course, the other worrisome thing is that with neurodegenerative problems, over time, unfortunately, things do tend to get worse. So any benefits that you might gain from exercises may be short-lived. So in the absence of that, of trying to fix it with exercises, what else could you do? Well, there's something called adaptive strategies that is saying, well, if I can't get the eyes to converge, how can I at least make it so it doesn't bug me? Well, the one easy solution is to patch one eye when you're reading. You can't have double vision from convergence if you're only using one eye. A more sophisticated way of dealing with it is to put prisms in your reading glasses, right? So one downside of using prisms, and it does work well when it works well, but reasons why it might not work well is that you need to get the exact, you need to get the size of the prism exactly right, okay, or at least close enough. And of course, if things change over time, you might find that the prism that works for you this month, in a few months, may no longer be big enough, and you might need to upgrade, which is not necessarily the end of the world. You can get plastic stick-on prisms that are easy to replace and less costly than having to replace the entire reading glass. Square wave jerks. These are not necessarily abnormal to have in and of themselves, but if you have too many of them, then we start worrying that maybe there's something going on. So these are small, rapid eye movements that take your eye away from where you're looking and then move your eye back. That's why they call it square wave jerk. So the tracing down below is showing you what this looks like if we were to record your eye movements, and the dotted line is where the target should be. The solid line is where the eye is positioned. And you see as the eye moves to the target, it stays on the target, then it gets moved off the target and then moves back. And that looks like a little square. That's why it's called the square wave jerk. So this is increased in Parkinson's disease, but is especially increased, and the square wave jerks are larger in progressive supranuclear palsy. And one of the things that people have shown in that condition is that the more of these you have, the slower your reading speed. So it does have some functional impact, but it's a bit subtle. Let's show you a video of somebody who has square wave jerks. I realize videos sometimes don't work so well on Zoom, but let's see if we can see these. You can see that little jig jig of the eyes there. That's the square wave jerk. Okay, I'll just show it to you one more time. There, you see it? It's going side to side, just a very small movement, just taking you off fixation. We don't treat square wave jerks, to be honest. We're more interested in what it signifies. So we don't really know anything about drugs to fix this. There are some sort of inadvertent observations, I might say, that deep brain stimulation, if you have one of those things, of the subthalamic nuclei, might actually reduce these things. But I think a common practical thing is, well, if you have a small little shift of fixation, well, that's going to have less impact upon what you're seeing the bigger it is. So if you read bigger text, then that slight shift in fixation may not take you off the word that you're trying to look at. Whereas you're reading very, very small text, that fixation might take you right off what where you're trying to read. All right. Vertical gaze palsy. Now, there's often been a lot of controversy about whether vertical gaze, this is where your ability to look up and down, right? That's what vertical gaze is. And usually we talk about saccades. And just if I haven't used the word saccade before, what a saccade is an eye movement that changes where you're looking. So if I'm looking at someone's face and then I look at another person's face, that shift of my movement over is very quick, and that's a saccade. Okay, that's different from a pursuit eye movement, where essentially there's a target that's moving and I'm trying to follow it. Okay, I'm not trying to shift my gaze from one item to another. I'm just simply trying to keep my eye on a certain moving object. So vertical gaze might be a little limited looking up in Parkinson's disease, but it's also something we see with just natural aging. So that debate goes round and round as to whether that's increased or not. But one thing we know is that in progressive supranuclear palsy, this is a condition that mimics Parkinson's disease. One of the key clues that this is what you have and not regular Parkinson's disease is that you have a far more obvious problem looking up and down. So the other features that also raise suspicion of this condition, which was first discovered in Toronto, by the way, in the 60s, is if you have early falls. That's rather, you don't have much in the way of tremor, if a lot of the stiffness you have is more in your neck and back than in your arms and legs, and that when you tried Sinemet or other L-DOPA kind of treatments, not much happened. So when a neurologist kind of sees his features and start wondering, I wonder if you have PSP and not real Parkinson's, you're going to end up seeing me. And they will ask, what do you think about the vertical gaze in this person? Do you think it's abnormal? Because if it is, then well, I'm going to diagnose him as PSP. So if you do have problems looking up and down, well, what might you notice that might make you wonder if you have it? Well, reading, for example, when we have books or tablets or things, we tend to read looking down. Now, if you're reading off a computer monitor, you're probably reading more straight ahead. So if you find that reading is kind of tougher with a book than with a computer monitor, one reason may be because you have a problem looking down. Likewise, if you're going downstairs and you're having a little trouble judging and seeing where you're going, that could be because of a down gaze problem. And we occasionally have people who fall downstairs because of this issue. Eating meals, again, we tend to eat from plates that are on the table, which means down below our head and our eyes. And one of the things that neurologists have coined is something called the dirty tie sign. This is a very male thing because I don't think too many women wear ties. But the idea that as they can't look down, so when they're getting their food, they're spilling it on their clothes. And of course, one of the challenges here for people with PSP is not only do they have trouble looking down with their eyes, but they can't tilt their head down to compensate for that because their neck's stiff as well. So it really makes these downward visual tasks really a challenge. So here's an example I'm going to show you of somebody who has trouble with vertical gaze. So first we can see side gaze. That's pretty good. It's fast and it goes right to the edge. So that's working pretty well. But then when you try to look up, you can see the eyes appear because the lids move up, but the eyes, when they try to look down, they don't get very far. You should be able to make your pupil edge go to the lid, and it's not getting anywhere near there. When they try to follow a moving target, they can sort of do it, but again, the range is limited. They can't get very far compared to when they move horizontally here, where they can get all the way from extreme right to extreme left. So that is a classic example from one of my patients who has progressive supranuclear palsy. So what can you do with this? Well, again, we don't have an easy fix for this. So you're going to resort to adaptive strategies. So one thing you could do is put prisms in your glasses that bend the light so that when you don't have to look, when you're trying to look down at something, your eyes don't have to move as far down. The prisms will bend the light to bring it to the eyes. And you can put this in both eyes. The other thing is, well, if I can't read a book in my lap, why don't I just put the book on a music stand in front of me so that I can read with it to kind of where a computer screen would be. That's a whole lot easier. I don't have a solution for the eating food thing other than maybe bring the plate up to closer to your mouth. Okay, number 4, ocular dyskinesias. This is a little different. This is where it's not that there's something you can't do, it's that your eyes are doing something you don't want them to do. Okay, these are excessive involuntary movements. So we know that some patients with Parkinson's disease, when they're treated with Sinemet, sometimes they have an on phase where the action of Sinemet is almost too much. And so they have excessive limb eye movements. You may have seen some people with this where they tend to be kind of restless and moving around a lot. And 10 to 15% of the time, you might see similar kind of movements in the eyes. Fortunately, the stuff in the eyes is not usually a cause of symptoms. If your eyes deviate a little bit, it's not necessarily something that you notice, interestingly. You can also create similar deviations like this with a subthalamic stimulator, which is obviously not something you want to try to do. Here's an example of a patient, not with Parkinson's, but with somebody who has an ocular dyskinesia. So you know what I'm talking about. So you can see she's trying to just look straight ahead. That's all I'm asking her to do. And you can see once in a while, she gets this little leftward eye deviation. Just takes her eye off fixation. So again, when I see this, I wonder, is this accompanied by limb movements that would suggest a dyskinesia and maybe be a sign that we need, again, to tweak the Sinemet dosing in some fashion. Okay. So The last thing I want to cover is this issue that I was asked to talk about today, which is, can eye movements help in diagnosing in Parkinson's disease? So I think it's important to clarify, what exactly do we mean when we use the term diagnosis? And there's several different ways you can use this. Okay. So the first is simply to say, well, can I detect if somebody has Parkinson's disease or not? Now, I phrased that way, detection, because a lot of the studies that have looked at this essentially are comparing people with Parkinson's disease and people who don't have any neurologic disease, so-called healthy controls. All right, which is fine as often a starting point, but really when it comes to clinical use, the patient comes to see you not because they think they're wondering if they are healthy neurologically or if they have a neurologic disease. They're coming because something's wrong. So what you as a neurologist are trying to do is trying to figure out, well, okay, so something's wrong. Well, what kind of problem is it? So it's not really a problem clinically of distinguishing between, okay, this person is in the healthy box and this person is in the Parkinson's box. It's really about trying to determine which of several possible disease possibilities is the issue. Okay. But there is perhaps another way of looking at this is when there's initial diagnostic confusion, can you detect a problem before other signs show it? We'll get to that. The second thing, though, and again, this is a related thing, is trying to say, okay, this person clearly has Parkinsonism of some sort. That's not in doubt. But I need to know what kind of Parkinsonism is it? Is this Parkinson's disease? Is it progressive supranuclear palsy? Is it multisystem atrophy? What? Okay. And that's often where I get asked to see a patient to try to help in that determination. And lastly, there's the issue where somebody has been diagnosed with Parkinson's disease, but people want to know, well, do they have some additional aspect of this disease process? So for example, there's often a lot of concern about whether there's not just Parkinson's, but Parkinson's disease with dementia. And I realize that sounds like a very unpleasant thing to have. Not only do you have trouble with your motor function, but now you have problems with your cognitive function too. And so one of the questions could be, can it help diagnose and detect those kinds of additional features? So 3 different questions you could ask about helping in diagnosing. Okay, so let's go through these. First thing is, can these eye movements help detect if someone has Parkinson's disease? And there's been quite a few papers kind of looking at this over the years. I'm just picking 2 at random from the more recent literature here, just to show you that's an ongoing thing still. So the top one, which just came out in January this year, is actually from somebody who works at UBC, Miriam Spearing's lab. I was in Yolanda Fukin's PhD doctoral thesis committee, and they wrote a paper on this, the finding that certain kinds of eye movements are affected in Parkinson's disease, but not all. So that's why they call it, it's stimulus and task specific. The stimulus specificity was that when they use moving targets, people with Parkinson's disease didn't seem to have problems making eye movements to moving targets. Task specific is the idea that, well, what kind of eye movement you ask them to perform might determine whether you see a problem. So anti-saccade errors. So I told you what a saccade is. That is when I'm looking at you, and then I want to switch to looking at somebody else. So I make a quick movement, or something appears suddenly on my side, and I look at it, which is often how we test it in the lab. We have a flash of light to the side, and we measure how fast and accurately somebody looks at that flash. But you can have something. Again, this is a Toronto idea from the quirky mind of Peter Hallett, who I had the honor of actually having trained with a little bit in Toronto. He had the quirky idea back in the 1980s that, well, if you don't always have to look at the target. Sometimes if there's a flash to the side, you can tell the subject, well, when that flash appears, look in the other direction. That's what an anti-saccade is, which has become a very useful tool of all places. So it's because it's a measure of inhibitory control. Can you inhibit the reflex movement of looking at the target and substitute a novel, very unpracticed movement, which is looking in the wrong direction? And if you and I do that, there's about somewhere between a 5 to 10% error rate. Yolanda found that people with Parkinson's had about a 35% error rate. Now, this is by no means specific to Parkinson's disease. People with depression and schizophrenia also have problems with anti-saccade errors, people with traumatic brain injury. So it's not going to be, you can't run this test and say, aha, this person has making anti-saccade errors, therefore they must have Parkinson's disease. You need to know the context in which it's happening. So it's not what we call specific. Right? Specific means it tells you that this disease is what's going on. It's not something else. Nevertheless, they've advertised it as, well, maybe this might be helpful in diagnosing. A very generic term. So the Zhang paper below is the finding that, well, there's not maybe one specific abnormality that tells you if you've got Parkinson's. Maybe we could do a combo thing where we say, if you have too many square wave jerks, or if you take too long to make a saccade, or when you make an upward saccade, it's too short, or if you have trouble following a moving target, which is pursuit, right? If you combine these things as indicators, you can get an index that is about 78% sensitive and 95% specific. So what that means is that if it's sensitive, that means that only 22% of people with Parkinson's don't have an abnormality on this test. Okay, 80% of them do. 95% specific means that only 5% of the control subjects, which were neurologically healthy people, had similar findings. So these numbers actually would suggest it's maybe not such a bad test. Maybe better for diagnosing than for screening, because 22% of people with Parkinson's will be missed by this test. But I know that really the question that came up was about diagnosing was this thing, about ocular tremor, which I haven't even discussed at all. Okay, what this was some work in neurologists in Virginia, and I've given the reference below if you're interested. The main paper was written in 2012, 10 years ago. And what they did was they recorded how stable people with Parkinson's could just look straight ahead of the target, okay? And what I'm showing you on the left here are two graphs over time. On the x-axis is time, and on the y-axis is position in space. Okay, so how stable are your eyes in space as time goes by? And what I will tell you from the y-axis is that these are very, very, very small micro movements, right? These are not things that you can see with the naked eye so much. And the top trace is a fairly steady black trace from a healthy subject. The red dots, by the way, is the head position. So that's just if there's any head tremor. But down below is a patient with Parkinson's and showing that the eye movements are kind of oscillating and wobbling around in this very small, minute fashion, but in a way that is quite different from the control that they saw. Now, obviously, they're picking some good graphs to try to illustrate what they're talking about. I will point out in the graph on the table on the right that these are patients who've had either Parkinson's for 6 years with medication or for about a year without medication. So we're not talking right at the beginning of the disease necessarily. And of course, these are patients who have been diagnosed with Parkinson's on the basis of neurologic criteria. A neurologist has seen them and has judged that by non-eye movement criteria, they have Parkinson's. And you're wanting to see how do the eye movements kind of look at in these people versus the healthy controls, so to speak. So I'm a little concerned by this because I've looked a bit more through the literature to see what else has been done on this. It's now being taken over by a commercial entity called RightEye. So this is where you might have heard about it. This is a company that is marketing a whole bunch of eye movement tests for things like autism as well as Parkinson's, using eye movements as a way of vision therapy. And there are some kind of red flags when I look at this, because I'm looking trying to think, well, does this work? Does it not? One thing that bothers me is below is that the last scientific article from this group that I could find was in 2014. So where's this going since? Why isn't there more data on this? And that article in 2014 was looking at 8 subjects to try to show that if they immobilized the head, then the eye tremor was still there. So they couldn't blame it on a head tremor, which one letter to the editor questioned that whether this eye tremor was an artifact of head movement. I think that's still a legitimate question, but nevertheless, that's like say the last scientific article. If you look on the West Virginia website, you see that they have a claim that thousands have been tested and that it is almost, with all their adjustments, it is 100% accurate. But again, where's the data? Why have we not seen that in the scientific literature? That's always a red flag to me when people make claims and I don't see the publications to back that up. The other red flag is this statement in the middle. If you look on this website and you go to that, you'll see this statement right up there. What does increased revenue per patient mean for your practice? And they have a calculator there to tell optometrists or physicians who want to buy their project how much more income they could use if they got their software and their hardware. And it's actually staggering. They're claiming that you look there that optometrists or physicians who buy this and use it frequently may make up to $200,000 more per year. So if a company advertises their product as increasing income revenue rather than providing clinical benefit, that's got to make you wonder something. So I will say that the problem with this stuff so far, and I don't necessarily say it's anybody's fault, but if you're trying to think, can I use this to diagnose Parkinson's? Remember that the studies we're talking about, you have to say, what they're comparing the results of the test with is the neurologist's diagnosis as the gold standard, right? The neurologist is saying these people have Parkinson's or these people are the healthy controls. So if you're measuring the eye test against that, there is no independent arbiter that says whether the neurologist is more accurate than the eye movement test, right? If you had an autopsy findings and these people for sure had Parkinson's, and then we can go back and look independently, did the neurologist get it right or did the eye movement test get it right? That would be helpful. But that's not something we do very often. In fact, really what we need is a study of patients at a very early stage when you come to the neurologist first, and it's not really quite obvious to either you or the neurologist that you have Parkinson's disease, okay? Or at least there's a lot of uncertainty as to whether or not you have it. So if you could test people at that point, do the eye test then, and do the neurologist's kind of opinion at the same time, you could then do a head-to-head comparison to see what happens when you see the patient again a few years later, when it's kind of obvious whether or not they have Parkinson's or not. So which of these is more accurate at predicting the future? That's what would be really helpful. And I haven't seen that yet. Maybe they're doing it, but that's the kind of data you need to be able to figure out whether it's going to be useful as an early detection tool. It may be, but I would need to see that data first before I go out and buy this thing and earn myself $200,000 more. Okay. How about telling between different types of Parkinsonism? Okay, this is a nice article here. And this is, again, where we often come in as neuro-ophthalmologists, right? People ask us to evaluate the eye movements. Hallucinations, sure. We talked about how this often would make you should at least think, could you have diffuse Lewy body disease if somebody's got hallucinations and Parkinsonism? Trouble looking up and down. We just talked about that. Progressive supranuclear palsy. Another one I didn't talk about was like gaze-evoked nystagmus or saccadic intrusions from unstable fixation on a big scale, not the little tiny traces in the ocular tremor I showed you. These might point to something called multisystem atrophy type C, where C stands for cerebellum. And I'll show you a video of what that looks like from someone who came to see me. Yeah, these are clinical things that we do, but these are much rarer conditions. So we don't have huge numbers of subjects to be able to say how useful certain kinds of eye movement abnormalities on testing might be in terms of splitting, telling these people apart. So this is usually relying on just our clinical observations. So here's an example. You can see this is side-to-side square wave jerks, quite a lot of them. Now you see when they looked at the site, there's this kind of big beat, regular beating. That is gaze evoked nystagmus. And pursuit is very scratchy. And here's another beat inside. And then you can see this big, large fixation instability as they try to look up here. Okay. That's more than just a square wave jerk. Okay. So those are the kind of things that when you see that, you got to think, okay, this is more weird than the standard Parkinson's disease. This is telling me there's something else going on. And this person was eventually diagnosed as multi-system atrophy type C. Finally, could it be a sign of early dementia associated with Parkinson's disease? Now, there are studies that look at this. One study found that stability of fixation tended to correlate with cognitive measures on testing. But again, you know, what we see here is that neuropsychological testing is the gold standard for cognitive decline, right, in these studies. So you can't prove that the eye movement is better than the testing. At best, you can show that the eye movements may be just as good as the neuropsychological test. And then the question comes in as to whether they are easier to administer than the neuropsychological test. Because the neuropsychological testing essentially is a half day of you sitting with a neuropsychologist, doing a whole bunch of tests of your memory and your attention and your visual spatial kind of perception, stuff like that. Whereas an eye movement test is essentially usually around 10 minutes. So there may be some practical advantages, but whether it offers superior accuracy or not, that's hard to determine. Again, you want to have a study where you can sort of administer these things and see whether the eye movements were predictive of cognitive decline in a manner that was as good as or better than the neuropsychological tests, which are more laborious. Okay. Anyway, I think that's it for what I wanted to talk to you. So this just to give you a reminder of what we talked about. This is the things that we went through. So I will move to, let's escape from that. And let's see, I see there are 8 things in the chat box. So I don't see anybody's pictures. So actually I can't tell if anybody's got their hand up or not, but in any case, let's.
No, you won't see their pictures, but if somebody raises their hand, I'll let you know. I can see that.
So I'll go through the list. If everybody can see in the chat box. So somebody mentions that they use eyelid cleanser every morning. Okay, so they're advertising they're making a claim or just putting a shout out for regular hygiene. Hopefully that helps you with keeping away the dry eyes and blepharitis stuff. Cataract surgery playing into any of this? So the only thing I can say would be that thing I mentioned about hallucinations, that if there is a potential role, and I can't say it's proven to have a huge role, but we do know in other situations that having really, really bad vision may predispose you to having release hallucinations. And it might be that having, you know, mildly bad vision in combination with Parkinson's will also predispose you to having hallucinations. So I can't say that I've seen a study that says that, you know, there's a 50% reduction or 75% reduction in hallucinations if you have cataract surgery, but is something that people have speculated about. Okay, a retinal detachment, someone asked about that. So not a Parkinson's thing, but not a good thing to have either, right? So a retinal detachment, when the retina comes off in the area that's detached, you're not going to see in that area. So you'll have a missing part of your vision in the area that's detached. If it involves the macula, which is the central vision, that's really concerning because the macula is the single most useful thing of your vision, right? Central straight ahead vision, that's what you use to read. You can't read with your side vision. Side vision is useful, but center vision is super useful. So if you have that kind of detachment, that's really bad. You need to see a retina specialist pretty quickly when you have this, because there are ways of reattaching your retina and improving your vision if you get it attended to quickly. Okay, so some of the ways you might know that you're having a retinal detachment is you might be aware that there's an area of vision that suddenly you can't see. And you might also have a lot of flashes and floaters. So a sudden shower of flashes and floaters should make you concerned that, uh-oh, something weird's going on. Even if you don't see a hole, maybe this is in the more far periphery of your retina, where it's a little harder to see the hole, but there's something going on. And if you don't attend to it, that hole might get bigger. Okay, someone asked about depth perception. Yes, not so well studied. Again, people talk about various subtle face recognition, object recognition things, and visual spatial functions as well. So not impossible. There are ways to measure depth perception in the clinic with stereopsis. This is like looking at 3D movies. If you want to figure out if that's why you're having this problem with the tile pattern on the floor, go to a 3D movie and see whether you can still see that. If you can, maybe there's something else going on with your tiles. Can I comment on plastic stick-on prisms? Yes. So a Fresnel prism, that's the same Fresnel term that as we talk about with lighthouse lenses, is a plastic stick-on prism. Okay. So the reason we have these is often to give people a chance to try a prism out without necessarily committing to it. You know, if we're not sure exactly what size is right for a patient, we say, well, let's try the plastic ones first, because if you get a ground and permanent glass prism, that costs a lot of money. You know, we're talking, I don't know, 300, 400 bucks, just like a bit more than a standard set of glasses. The Fresnel prism costs about 40 bucks. So what you do with them, it's a big round thing. Every optometrist or ophthalmologist has a bunch of these in their shelf, in their drawer. So they should be able to get one of these for you. And they'll look at your glasses and they will take a pair of scissors and cut out a shape of that plastic thing that will fit onto your prisms, onto your glasses. And you stick it on with a little bit of water, squeeze the bubbles out, and off you go. And you can take that off and on to clean it or whatever. Okay. It's not quite as clear as proper glass, but it's at least a good way of at least trying out to see if the prism will work more or less for you to eliminate the double vision. Convergence exercises. No, I'm not sure there's a link. I've never bothered to look for a link. There might be one. But the orthoptist departments can often, or optometrists can guide you to them. The orthoptists will often teach you how to do the home exercises. They don't, at least the ones I know, don't tend to do the in-office exercises. The optometrists do have this. As I said, the studies for this have been mainly in children. And they do suggest that the in-office exercises are better or more effective than the at-home ones, but that comes at a bit of a cost, right? Every time you do these vision therapy sessions, it's something like 170 bucks a shot. And they'll often recommend you doing 6 to 10 of these. So it's a bit costly. I'm a little reluctant to recommend it to people with Parkinson's because, again, I am not aware of data that says that in a neurodegenerative condition or even with mild brain trauma that these really work when there is neurologic damage. It's not just children born with slightly deficient convergent systems. Okay, if you ask what they are, yes, often it is a situation where you're trying to look at something that's far away from you and then you're moving it closer to you. This can be as simple as like an object on a string that you can move up and down the string. You can do it on a screen, where the fancy thing with the screen is you give like polarized glasses. So one eye sees one image, the other eye sees the other, and you can make those images move closer or back so that it sort of simulates an object closer to you or further away from you. Or like I say, the same thing at home is the whole looking at a pencil and trying to move it close to you, where it starts to break into two. You hold it there and see whether you can hold that as a single vision with some effort and see if you can keep doing that and see if it gets easier and you can bring the pencil closer to your face without getting double vision. So Penny asks, should she look for someone with a neurologic specialty? Well, kind of depends upon what question you're asking. If you think you have dry eyes or blepharitis, no, you don't need someone with a neurological specialty. You need somebody who an optometrist can do this in their sleep, right? They can handle you with dry eye stuff. Generally, if you're having double vision and stuff, it's good to see a general ophthalmologist or optometrist first to make sure that this isn't some simple problem in their domain before you end up seeing a neuro-ophthalmologist. So if you have double vision, for example, and you close one eye and you still have double vision, then that's not because your eyes are misaligned, which is why you're usually ending up to see a neuro-ophthalmologist. It's because the light getting into one eye is being bent and distorted a little bit. And that could be anything from a dry eye problem, or it could be a cataract. So, those are certainly things that an optometrist or ophthalmologist can detect. But they do need to kind of clarify the question, is it a one-eye problem or a two-eye problem? Yeah, so Carolyn asked about the retinal detachment. So it was attended to, yeah. So long-term usually can be fairly stable. I don't follow people with retinal detachment because that's a retinal specialist's job. So I can't really give you great advice on that. But I have seen people who, who come to see me for other reasons who have retinal detachments or had them before. And the fix actually worked quite well for many, many years. Bifocals. Can bifocals cause the same up-down eye movement problems? No. They can be a problem in somebody who has up-down eye problems, though. Remember, if the bifocals are set up so that when you want to look close, you look through the bottom part of your glasses, right? That's how they're set up. Even progressives have the same idea, that you use a different part of the glasses in front of you for far and for near. And the general setup is that most people, when they're looking far, are looking down the road straight ahead. So the top part of your glasses are for far. And when you look up close, you might be looking more down at, your lap or book or the plate in front of you or whatever. And so for that, you might be looking through the lower part of your glasses. Well, if you have trouble looking down, that's not going to work for you, right? You can't move your eyes to take advantage of the bifocal part. So if you have trouble with up and down eye movements, you're better off getting separate readers and separate far glasses. So Barbara Zimmer asked about the preservatives. There are preservative-free ones. They're sort of like one-use things, terrible waste of plastic containers. This is an individual thing. I'm not fussed about it too much. When I use it myself, I don't really care. It works fine. I'm not worried that I'm getting exposed to anything weird. In fact, if you're going to have these things sitting around at the bottom, it's probably better to have a preservative than to worry that there's going to be stuff growing in it if you sit in your cupboard. So, but some people are sensitive to it. If you have trouble with it, try the preservative-free ones and see if that's more comfortable. Because the last thing you want to do is put something in your eye that's for your eye irritation, to find that whatever you're putting in also irritates your eye. Joan asked about her husband having great difficulty keeping his eyes open. They close and he cannot open them frequently. Yeah, I didn't talk about this very much. Eyelids are also an issue that can be abnormal. As I mentioned, the most common problem with Parkinson's or Parkinsonism is reduced blinking. But there are some people who have something called blepharospasm. This is, again, one of those involuntary eye movement kind of things. Like we talked about the dyskinesias, but you can also have essentially a dyskinesia of the eyelids so that your eyes can squeeze shut and you have trouble opening. That's what blepharospasm is. There's a mild form of blepharospasm where it's only the muscles on top of your eyelids, not the muscles around the eye. And for those people, it kind of looks like they can close their eyes, but they can't open them. And they will kind of struggle and their eyelids will go up and they just can't feel it, and then it suddenly clicks in. So these are all essentially a form of what we call a focal dystonia, right? Writer's cramp is a focal dystonia. So these are the best treatment for a focal dystonia is Botox, right? You weaken those muscles a little bit and their involuntary movement becomes less bothersome. People used to use a lot of oral medications in the past. I remember those days before Botox, and the efficacy of other medications is pretty crappy, right? So if you have a problem with this, Botox may be the best way to go. And the one thing, though, is to make sure that the reason that you can't keep your eyes open is because they hurt. Okay, some people with a lot of dry eye problems find we call it secondary blepharospasm. They're keeping the eyes shut not because there's some involuntary movement going on, but because it's more comfortable that way. And when they open it, it lights bother them, or the surface is uncomfortable. So for those cases, you don't want to treat with Botox. You don't want to address the underlying problem. Winston asked what type of muscle controls eye movements. So you have in each eye 6 small eye movements, eye muscles that move the eyes around in all 360 degrees of directions. These are skeletal muscles. Okay, they're not smooth muscle like what's in your gut. right? They are skeletal muscle, like what's in your limbs. They do differ a little bit from limb muscles. They have sort of higher mitochondrial content that they're used to tonic, because there's no moment in your waking day when you're not using your eye movements. Your eye muscles, you make an eye movement essentially 3 times a second while you're awake. So these are highly active muscles, and it's one of the things that distinguishes them from limb muscles. So I don't think that necessarily makes them more vulnerable to Parkinson's, because it's not the type of muscle that determines whether Parkinson's affects you or not. Parkinson's is about a central control, right? It's not about peripheral muscle disease. Muscle diseases do have, some muscle diseases do have a preference to affect the eye muscles, like myasthenia, for example, because of muscle properties. But that's not the issue with Parkinson's, because that's not a muscle problem. It's a central control problem. So really, it's all about where in the brain are there control problems happening. And it just so happens that the structures that control vertical gaze and convergence are pretty darn close to where all the action's happening in Parkinson's disease. All the structures that are involved with looking sideways, though, are lower down in the pons. So those don't take a hit in people with Parkinsonism. And like in the video I showed you, the person with a vertical gaze palsy, that sideways movement is not an issue. Now, Franco Scarfoni asks an interesting question. Does dopamine affect acuity, color vision, and contrast? And Franco, the short answer to that is, I don't know. I haven't thought about that. Someone may have looked at it, but I haven't run across that research if somebody's done it. But I'll go look. Simon writes, I have too much tears and they overflow, interfere with their vision. Is this common in PD, which I've had for 6 years? Yes. So remember what we talked about when you have dry eyes and the surface of your eye gets a bit irritated. You may or may not feel that irritation. You can't use the feeling of irritation as a reliable guide as to whether your cornea is drying out, unfortunately. But if your cornea dries out, then one of the things that your brain will do when it senses that drying or even the discomfort is that there will be a reflexive tearing. When you get something in your eye, you get a bit of sand or stuff in your eyes, you will tear, because that is a protective reflex against eye cornea pain, right? And so that's often the most common reason why tears overflow, is not because there's a primary problem making too many tears. It's more a problem that your eye is a bit too dry, your cornea is not quite lubricated enough, and so you get a reflexive tearing. So the solution there is not to try to dry your eye out, it's to try to make your cornea more comfortable. And usually that involves doing dry eye treatments. Franco asked about blue lens glass TV when watching TV. If you are a bit light sensitive, and that's why you're wondering about wearing lenses, the first thing is to make sure you don't have blepharitis or dry eyes, because the treatment for that is the lid hygiene. It's not worrying about the lenses. Okay. You can have photosensitivity for other reasons, but it's not usually a Parkinson's thing. I mean, for example, we see a lot of people with traumatic brain injury who complain of photosensitivity. It's a bit weird. We don't really kind of understand exactly how it's driven. There is some thought that it's maybe some special neurons in the eye that project to the hypothalamus parts of the brain that are involved in more, well, anyway, things like day-night diurnal rhythms and stuff like that. But even there evidence that certain types of lenses are better than others is a little fuzzy. Okay, people do recommend blue blockers because they think those affect those kind of neurons more, the kind of light that those neurons absorb. But again, the studies that I've seen for this with traumatic head injury don't bear it out that that is the solution for everybody. In fact, a lot of the studies seem to find that people prefer different kinds of lenses. And the ones that they choose to use after the study's over tend to be all over the place. So I usually tell people, if you want, you can go try what a blue blocker feels like, but don't be afraid to ask the optometrist if you can try some different kinds of filters and see if some of those are more comfortable for you if you are having light sensitivity with watching TV. The other thing you could do if TV bugs you, which may be less finicky, is see what you can do by just turning down the contrast. Drinking enough fluids for dry eye. Yeah, that might help. But again, if you have blepharitis, that may not be enough to get around the situation. It's helpful, yes, to pay attention to some other factors that you can do something about. If there's a lot of wind in your face, for example, that's usually where I get dry eyes because I'm out riding my bike for 4 hours. That's when I get it. Another situation that some people notice is that if you have a CPAP machine, you got sleep apnea or something, and you have this machine that you wear at night that tends to blow a stream of air. If the mask on your face doesn't fit properly, you might get a stream of air against your eye all night long, and that's going to dry your eye out. So yeah, paying attention to other factors, non-eye factors as well, like airflow and fluids might be helpful in some cases. Angela talks about having vision problems for 5 to 6 years after Parkinson's diagnosis. So she's skeptical about whether it would help in early detection. Well, you're absolutely right, Angela. I think that's what we need to sort out, right? All these tests, all these studies where they're simply testing people who've had the diagnosis already for a number of years might tell you that there is something abnormal about the way the eyes move, but it won't tell you about whether it's helpful when you study somebody really, really early on. Those studies need to be done, but they're hard, right? Because you have to follow people for a few years to figure out what the answer is. So they are studies that need time to be done and some patience. And you find that for that reason, they tend to be more unusual things that people do. Karen wanted to know about the eyelid regimen for crusty eyelids. So this is the whole thing about getting a warm compresses, like a face cloth that you've warmed up under the hot water, not boiling hot. And then with your eyes closed, just placing that gently over your eyes and keeping it there for a few minutes, and maybe even massaging and moving the cloth across your eyelids from inside to outside to see whether you can gently remove some of the crusting. Again, some people find that putting a little bit of degreasing baby shampoo on the washcloth might that be more effective. We don't want to put anything too strong. Chris asks, is optic nerve palsy a symptom of Parkinson's? So first of all, optic neuropathy, Chris, is not a palsy. Optic neuropathy is where the optic nerve is responsible for seeing vision and bringing visual information from your retina to your brain. A palsy is a weakness. So you can have ocular motor palsies where the nerves that go to the muscles to move the eye around don't work, and you see double vision because of that. And optic neuropathy is not a palsy. It is essentially a failure of transmitting light from your retina to your brain, either in part or in whole. So, but the short answer to that is no, neither of them are Parkinson's disease problems. Karen Hall asks, with looking down, what lens do I recommend? Okay, so progressive prism lenses. Now, I'm not sure what that is. A progressive lens is where, that's like the bifocals kind of stuff. That's where you're changing the refraction so that you can focus up close as opposed to far. A prism, usually when people put prisms on lens, they only put one prism. Although they can put a partial prism where they just put the prism over the bottom part of your lens. So that's one solution for this situation. You can, and this is where you would use a plastic prism. You cut out a patch of prism that would fit not to the entire lens, but just to the bottom, so that when they're trying to look down, they can look a little further than their eyes will let them. So you could try that out and see if that works for you. Okay, I think that's it. I think I've reached the bottom of the questions. Anything else? Anyone else?
Dr. Barton, I think we have, or we did, let me see, a couple of raised hands. So Stephen McCarthy has a question. Stephen, go ahead. If you will need to unmute though.
Well, thank you, Dr. Barton. That's a tremendous presentation you've given us. Thank you so much. I experience a vertical stacking of images, which particularly off in the distance, and this diminishes as I get closer to the object. the stacking can also be eliminated if I cover one eye or close one eye. And I'm just wondering what may be causing this, if it's a Parkinson side spin or if it's something quite unrelated. But
yeah, so you're saying that you essentially have vertical doubling of your images.
yes, if I looked at a stop sign, for instance, or
Yeah.
you know, I would, particularly if it was in the distance, I would get that result. But as I got closer to it, the stacking would disappear.
Yeah. So one thing you need to do, you say it goes away when you cover one eye. You have to make sure it goes away when you cover either eye.
Yeah,
Okay?
and that's the case.
Because if you find that it's in one particular eye, then that could be a retina problem.
Okay.
A cataract or something like that. If it is a binocular problem, which is what we call it when it's only present with both eyes open, then yeah, there's some sort of ocular misalignment going on. So you probably need to have somebody assess you to figure out why that is. It's not the most common thing to have vertical double vision in Parkinson's disease. Okay. So yeah, you would need to kind of have someone look at you to figure out. So one of the things that's often a clue with double vision of any sort is trying to figure out how it changes with where you look. So you've done the near far thing, but what can be very helpful with vertical double vision is whether it changes. In other words, the images get further apart or closer together when you look up, down, left, or right. Okay, and that can kind of often help us figure out, is it a particular muscle that moves your eye that is the problem? Does it fit a pattern that's recognized with certain kinds of eye movement things? So for example, one common thing that causes vertical double vision, often with a slight horizontal displacement, is what we call a fourth nerve palsy. Okay, and some people are born with fourth nerve palsies and can hold it together most of their life, but later on, for whatever reasons, they've got other, neurologic problems or illness, then their ability to keep those two images together starts to kind of become an issue, and they start to see double. So, but I can't tell you that you have this relatively more benign problem until we sort out the pattern that you have and determine, is it what it's telling? Does it fit with a brain issue, or does it fit with a nerve issue or a muscle issue?
Right. I didn't experience this until I guess about a year before my diagnosis.
Yeah. So if you've had it for a while, that's kind of good news. You're not dead yet, right? So it can't be something too bad.
So far.
But there's still a question. Well, what is it, right?
Yeah.
So yeah, you need somebody to kind of sort that out for you. I would not right off the top just say, oh, well, that's the Parkinson's.
Okay, thank you.
You need someone to kind of look at that and say, okay, that's a bit weird. Horizontal double vision up close, yeah, sure. That's we hear that all the time. But vertical, let's just make sure that we characterize this and see if it's telling us that there's something else that you need to know about.
Thank you.
Let me see.
I think that's all of the questions, Dr. Barton.
I see Mervin's got something else here. Is it common for someone with Parkinson's with 20/20 vision to have blurred vision and difficulty reading a newspaper? So again, Mervin, yes, this can be an issue. If you're 20/20, remember you measure 20/20 with each eye by itself, right? But if you're reading a newspaper, not only do you have to have 20/20 vision in both eyes, and of course, if you're on the older side, maybe you need to check to make sure you still have 20/20 vision when you're looking up close with appropriate reading correction. That's the first thing, right? But even if you have appropriate 20/20 vision with correction for up close, you may not have assessed the idea of, well, if you have this convergence problem, right? If you can't quite move your eyes together, then it can look a little blurry and reading will be a bit difficult. So that's what you need. You need to make sure that somebody checks to see that you have the appropriate readers for close, and also that your eyes are converging properly when you're looking up close. Either of those could be an issue if you're having blurred vision with reading. Okay, I think that's it.
Dr. Barton, thank you very much for sharing your expertise with us in a very informative presentation today, and also staying past time to answer all of the questions. Much appreciated. And thank you all for attending. And thank you all for your great questions. Have a great afternoon, and we will see you at our future webinars.
Take care.
Bye, everyone.